So hello everyone, we are moving to the next module. The next module is a very important one on pulmonary thromboembolism. So this is again a favorite clinical case based scenario that an examiner can ask you for your exams. So pulmonary thromboembolism. Now in a pulmonary thromboembolism, the source of the thrombus, okay, there has got to be a source of the thrombus for it to embolize, and the source of the thrombus is often a deep venous thrombosis, okay, that is a deep vein thrombosis of the veins of the lower limbs. So what are the veins which could act as sources for this embolic event? Often it is the lower limb veins, that is including your soleal vein, the popliteal vein, the femoral vein, and your iliac veins. So all these veins would serve as the source of thrombus. Now let's see how does it propagate. Once the thrombus is formed in the veins of lower extremities, I am showing you a pictorial representation. As you can see here, there is a cross section of a lower limb vein is being zoomed, and you can see that thrombus formation happens there. Yes, and as you might appreciate here, the thrombus formation is often at regions where there are venous valves, okay, venous valves, because at sites of venous valves, it is likely that the normal streamline flow of blood is slightly interrupted, okay, and because of that there is a chance of thrombus formation. So often the region of the valves would serve as the nidus for the thrombus origin, okay. Now once the thrombus forms, it gets dislodged, okay, it gets dislodged, and the thrombus is traveling via the venous system through the inferior vena cava. It enters the right side of the heart, and through the pulmonary artery it enters the lungs, okay. So that is how the pulmonary thromboembolism episode happens, okay. Now the severity of manifestations would depend upon what is the size of the clot that has been dislodged from the lower limb veins. Obviously, if you have a large clot which is dislodged, it can go and impinge on a large pulmonary vessel. So the manifestation and the hemodynamic consequence also would be a larger one, okay. Alright, so that is what happens in a pulmonary thromboembolism. Now I told you the first event has to be the formation of thrombus. So the question arises, see, how does thrombus formation happen, okay. So why does the thrombus formation happen in the lower limb veins? So for the thrombus formation to happen, you have learned in your pathology lessons that you have the famous Virchow's triad, okay, Virchow's triad. And you tell me what are the components of the Virchow's triad. You have a stasis of blood flow, okay. Normally you have a streamlined laminar flow. So if there is some stasis or maybe even a turbulence of the blood flow, there is an increased chance for thrombosis. Whereas in a normal streamline flow, it is less likely that a thrombus might form. Second is hypercoagulability, which means there are certain conditions that can predispose to thrombus formation. Okay, a lot of conditions which can predispose to thrombus formation, like a protein C deficiency, protein S deficiency, antithrombin 3 deficiency. Lot of hypercoagulable states are there, again can predispose to thrombus formation. The final one is the endothelial injury, okay. So whenever there is an endothelial injury happening, again the chance of a clot formation is also high. So it is when any of these components of the Virchow's triad, either individually or when it occurs in combination, you have a high chance of a clot formation. Very clear, that is what you call your Virchow's triad. Alright. Now see, these are the theory points, okay, the factors predisposing to thrombus formation. But translating it into clinical practice, what are the scenarios in which you can expect a thrombus formation in the the venous system. So let's have a look at the clinical scenarios. Okay, that the clinical scenarios predisposing to venous thrombosis. So stasis, okay, we are just describing the Virchow's triad in terms of the clinical scenarios. See, one important point is immobility and bed rest. Now this is very, very important, because in your exam a common case scenario that might come would be maybe a 60-year-old female, okay, obese female. She has developed a fracture of neck of femur. She has developed a fracture of neck of femur, and she is admitted and subsequently has a history of a prolonged immobilization. Okay, so following the fracture, naturally her mobility will be restricted. So there will be a prolonged immobilization. So she might be having an uneventful hospital stay, and suddenly, she might develop features suggestive of a pulmonary embolism. Okay, so here what has happened is that the prolonged immobilization is the one that has triggered the thrombus formation in the individual. Okay, and does it occur in all individuals? Okay, see, it's often a combination of factors. If you have an obese female, remember I specifically told obese female because sometimes contributory factors like obesity, which again can predispose to thrombus formation. So when it occurs in the when the immobilization occurs in the context of an obese female, then there is the likelihood of development of thrombosis is more. Okay, and prolonged bed rest. Then other conditions, like suppose a patient would have had a congestive heart failure, so which means your blood flow is not the normal laminar flow, you are having turbulence, and a history of prior thrombosis also might predispose to a stasis in the blood flow. So all these can predispose to thrombus formation. Now this is very, very important, because see, that can explain why a patient with a congestive heart failure may develop a pulmonary embolism, because his circulation is relatively a static one compared to the normal laminar flow. Okay, all right, because you have got to know the clinical scenarios, only then you will think of a possibility of pulmonary embolism. See, pulmonary embolism is most often a clinical diagnosis, to at least to begin with, because you have got to have a high index of suspicion. Otherwise, you might be recognizing a pulmonary embolism only after the patient has gone for severe hypotension and other complications. Okay, hypercoagulable states. See, you remember I already told you about the protein C, protein S deficiency, but there are a lot of other conditions contributing. Malignancies, especially malignancy per se itself is a procoagulant state, especially certain malignancies like a pancreatic malignancy, AML M3, then a prostate malignancies. So certain malignancies are hypercoagulable states again compared to the others. You can have a thrombotic state in the setting of a gastric carcinoma as well. Okay, then anti-cardiolipin antibody. Okay, you know that anti-phospholipid antibody syndrome, APLA, which we have discussed in detail in the rheumatology chapter. So this is again a condition that can predispose to thrombosis, this APLA syndrome, which can either occur in isolation or secondary to SLE. You can have a anti-phospholipid antibody syndrome. Nephrotic syndrome, the other conditions like essential thrombocytosis, estrogen therapy, especially in those females with long-term intake of oral contraceptive pills. Okay, again is a prothrombotic condition. Heparin-induced thrombocytopenia, you know that it can predispose to thrombosis, that is your HITT, heparin-induced thrombocytopenia with thrombosis. Inflammatory bowel diseases also can predispose to thrombus formation. PNH, DIC, all are hypercoagulable states. So you always keep these hypercoagulable states in your mind. Then vessel wall injury in the setting of trauma, surgery, especially the pelvic surgeries. Okay, especially the pelvic surgeries are likely to trigger a thrombus formation. So keep all these in mind. Remember, I initially told you about Virchow's triad, but the importance of this table is that this is going to be the setting or the clinical scenario that you are going to have in your exam, where they may put in a case scenario of a pulmonary embolism. Okay, so you have got to have a high index of suspicion, in what clinical scenario does a pulmonary thromboembolism develop? So that has to be kept in mind. Okay. So I hope that is very clear to you. Okay. So you understood how the pulmonary thromboembolism happens. Now we are going to see what exactly happens. Okay. What is the physiology? Okay. What is the pathophysiology of the various consequences of the subsequent clot formation? See, suppose you have had a dislodgement of a thrombus from the veins, it goes to the pulmonary artery. Okay, so you have a pulmonary clot, okay, in your pulmonary circulation. So what impact does it have? Okay, that is what we are going to learn. What impact does it have? So I'll just show you a picture. Okay, we're going to learn the impact. You see here, this is the alveoli. You have a clot in your pulmonary artery, and this is where normally the gas exchange should take place. Okay. Now what happens in a pulmonary embolism is there any problem with the normal, say the ventilation, because the airways are perfectly fine, correct? No, the airways are perfectly fine, the oxygen is actually coming to the alveoli. But what is the problem? Since you have a clot here, the perfusion is affected. Okay, so since the perfusion is affected, there occurs a ventilation perfusion mismatch. So what happens is that at the capillary level, you have the oxygen that is reaching the alveoli, but for the gas exchange to happen, you've got to have a blood flow also to the region. See here, because there is an embolus blocking at that site, there is no perfusion happening here. Okay, there is no perfusion happening here. Now it is because there is no perfusion happening here, it is almost like a dead space ventilation. Okay, there is a dead space ventilation that happens. Okay, there is a dead space ventilation. There is an increase in the anatomical and your physiological dead space. So the consequences is starting with this, that there is a dead space ventilation happening. So when there is a dead space ventilation happening, what all are the consequences? You will get a pulmonary hypoxemia, because you are not having oxygen that reaches the blood in sufficient amounts. Okay, because the blood actually is not reaching the capillaries. So there is a pulmonary hypoxemia, and second is there is an increased PaO2 minus PaO2. What is this? This capital A is the alveolar oxygen tension, and the small a is the arterial oxygen tension. So what happens is, the normal gradient is around say 5 to 15 millimeter mercury. What is that gradient? It is the pulmonary alveolar arterial oxygen tension gradient. Okay, oxygen tension gradient. So this gradient normally is around 5 to 10. But what happens in case of pulmonary embolism is that, see your the arterial oxygen, what do you say? It will be normal or it will be reduced? Definitely will be reduced, because the arteries are not getting enough oxygens. So because of that, in case of pulmonary embolism, this gradient increases, because the alveoli is having oxygen but the arteries are not having oxygen. So the gradient is actually increasing. Okay, so the gradient increases, and then what are the other physiological changes that happens? The dead space ventilation, I have already told you. Then there is a decrease in the pulmonary compliance, the decrease in the lung compliance. Okay, there is a decrease in the lung compliance, and also there will be a alveolar hyperventilation. Okay, in an attempt to, because of the perfusion ventilation mismatch, the receptors will be stimulated and there will be a compensatory alveolar hyperventilation. So these are the physiological changes that occur because of the blood clot that is blocking your pulmonary artery. Okay, very clear. All right, now let's see again what are the further changes that happens. See, suppose you have got a clot. Okay, this is the heart, you can see. This is the right atrium. The right atrium, you have the right ventricle here, left atrium and left ventricle. Now, if you have a clot in your, say, your pulmonary artery. Okay, suppose you are having a clot in your pulmonary artery. Okay, there is a big clot lying in your pulmonary artery. So what happens is that there is an obstruction of the flow from the right ventricle through the pulmonary artery to the lungs. So what happens is that as a first step, because of this occlusion, initially there will be naturally a hypoxia. Okay, and when there is a hypoxia, there occurs a pulmonary vasoconstriction, and subsequently what happens? A pulmonary hypertension happens. Okay, pulmonary vasoconstriction and a pulmonary hypertension that happens. So that happens as a first step. So when there is a pulmonary vasoconstriction, just think of the plight of the right ventricle. This right ventricle has to pump against this obstruction as well as the vasoconstriction. So do you think right ventricle would find it easy? No. So what happens is that there, as a next step, okay, as a next step, the RV, right ventricular dilatation and dysfunction would happen. Okay, right ventricular dilatation and dysfunction would be happening, and when it happens acutely in the setting of a, say, a massive pulmonary embolism, you call it what? Acute cor pulmonale. Okay, acute cor pulmonale. We have already learned the chronic cor pulmonale that can occur in the setting of a COPD, but here there occurs acute cor pulmonale. There is a RV dilatation and dysfunction. So when there is a RV dilatation and dysfunction, naturally you are clear that the right heart is failing. So you will have a elevated JVP, correct? There is a elevated JVP, and you may also have a Kussmaul sign. Okay, Kussmaul sign, that is your increase in the JVP with inspiration. So the JVP is elevated, there is a failing right heart, RV dilatation and dysfunction. And what happens is that since the right heart is somehow trying to pump out the blood, but it is not happening, another feature that might happen is that your interventricular septum, that is between your RV and LV, there will be a bulging of the septum towards the side of the left ventricle. Why? Because there is so much of blood in the right ventricle, which it is not able to pump that. And because the blood accumulates, it would press on the interventricular septum and push it to the other side. So thereby what happens is that though the problem is in the right ventricle, okay, the right ventricle is not able to pump, the LV cavity is also decreased. Okay, so what happens is that the LV end diastolic volume is also subsequently decreased. So when the LV end diastolic volume is decreased, what will happen to the cardiac output and the systolic blood pressure? There is a decrease in the cardiac output and a decrease in the systolic BP. Okay, and the patient may go for a hypotension. Okay, so these are the sequence of events that happens in cases of a pulmonary embolism. But see, out of the changes that I have listed so far, it is often the size of the clot and what is the vessel that is affected that determines the severity of the hemodynamic consequence. Okay, if you have a large clot that is occluding your main pulmonary artery, it would be disastrous complication resulting in so much of a hypotension, patient in a shock. Okay, so that is again dependent on the size of the clot and the vessel that is involved. Now just a summary diagram of what we have learned so far. There is initially pulmonary hypertension, subsequently the RV overload, afterload increases because it has got to pump against resistance. There is RV dilatation, maybe secondary tricuspid regurgitation, and the RV wall tension also happens. Okay, so because of the increasing right ventricular wall tension, it can also compress the coronary arteries. Okay, it can compress the right coronary artery, And whenever the coronary artery is compressed, what will happen? There can be a myocardial ischemia. Myocardial ischemia. So already the RV is not able to pump enough blood. On top of that, because of the tension in the RV, you are also getting a myocardial ischemia. So there will be a myocardial cell death also, which can very well resemble your myocardial infarction, and this is called a microinfarctions. Microinfarction. Harrison has mentioned it as a microinfarction of the RV. Okay, microinfarction of the right ventricle happens. So already there is a oxygen demand, and on top of that you are having a ischemia of your heart cardiac wall as well. So there will be a RV ischemia and hypoxic injury, subsequent decrease in the contractility, decreased RV output, and subsequently what happens is that the septum bulges to the other side, the LV preload also decreases, the cardiac output, systolic BP. Again, when the systolic BP is affected, again you know that from the vessels, the aorta, you have the coronaries arising. So naturally the coronary perfusion will again be affected. Okay, so subsequently the patient can progress to a shock. Okay, and if untreated, even death. So this is the vicious cycle of events that occurs in the setting of a pulmonary embolism. Okay, so you understood the what of a pulmonary embolism and the why of the pulmonary embolism. Okay, all right. So having understood that, let us move to the clinical features. Clinical features of pulmonary embolism. So first of all, let me tell you one thing. Each and every patient with a pulmonary embolism or a suspected pulmonary embolism won't be having exactly the same features. You can divide your pulmonary embolism into three types. Okay, the three types. So one is a low index pulmonary embolism. Okay, low index pulmonary embolism. Then you can have a submassive pulmonary embolism, and you can have a massive pulmonary embolism. Okay, massive pulmonary embolism. So there are three scenarios. So low index pulmonary embolism means the patient is having some features, but again it's almost like a clinical suspicion that you are having. Submassive would be having more obvious clinical features, and massive will be the one in which the patient would be having severe symptoms. So I told you this can be a continuum. Okay, a patient who initially might look like a low index pulmonary embolism might then progress to a submassive or maybe even a massive pulmonary embolism. So let's see what are the clinical features. The most common symptom of a patient with a pulmonary embolism would be a dyspnea. Okay, most common symptom would be a dyspnea. He may also have symptoms like chest pain also. He may also have symptoms like chest pain, but the most common symptom is a dyspnea. Okay, and this dyspnea often may be a dramatic onset of a dyspnea, because see, if it is an acute pulmonary embolism, I told you the presentation may be in the setting of a prolonged immobilization. You remember the elderly obese female who had a neck of femur fracture and was immobilized, developing a acute onset breathlessness. So the onset may be dramatic. The patient might have been perfectly fine maybe another say 15 minutes or half an hour ago, and the onset will be dramatic. Okay, so the patient would be having an acute onset of dyspnea, chest pain, and when you examine, you might find that the pulse rate of the patient may be high. The patient would be having a tachycardia. And what about the blood pressure? See, that again depends. In a submassive and a massive pulmonary embolism, the blood pressure is likely to be on the lower side. Okay, there will be hypotension. Okay, but maybe in a low index pulmonary embolism, the blood pressure may be relatively normal because it is at a compensated stage. Okay, so there will be tachycardia, hypotension, and there will be tachypnea as well. Okay, there will be tachypnea. Okay, and when you examine the patient, see, the features are predominantly with respect to a right heart failure. So you might have a feature of right heart failure like a elevated JVP, and if the right heart failure has been present for some time, then you might get a pedal edema as well. Pedal edema as well. So you might be able to demonstrate the Kussmaul sign. And on auscultation, see, one finding that you might get in auscultation is that I already told you the right ventricle is overloaded with blood. So what do you think about the time that the pulmonary valve would take to close? It would be increased, right? So the A2-P2 gap, okay, or the split gap would be widened. So you will get a wide and probably a fixed S2 split. Okay, wide and a fixed S2 split may be seen on auscultation. Now what about features of left heart failure? See, I told you that happens only very late. Okay, usually this is a predominant right heart failure, and even when there is a left heart involvement, it is just that the preload is decreased. Okay, preload is decreased and the hypotension happens. So often you will not get any features of pulmonary edema in case of pulmonary embolism unless it is in the late stage where it is a biventricular failure. But otherwise, no pulmonary edema, your chest will be clear. Okay, so these are the examination findings that you can expect. So severe hypotension means the patient might have cold, clammy extremities as well at presentation, because this is an acute cor pulmonale presentation. Okay, so this is the clinical features of an acute pulmonary embolism. Now suppose you are having a patient in your ward. Okay, after listening to this lecture, probably tomorrow you are seeing some patient in whom you are suspecting a pulmonary embolism, or probably you are very sure that this is a pulmonary embolism. So is there any tool that helps you to say the probability of a pulmonary embolism? Well, there is a Wells clinical prediction scoring, okay, for pulmonary embolism. Okay, this is very important. They may ask you as a factual question, but you have got to know regarding the components of the Wells score. So the Wells remember it's a clinical prediction score. Okay, so what are the components? See, this is just a rough guide that helps us to determine, what is the probability of pulmonary embolism in the current episode. So one is that we are first going to see the components. Okay, so the components are: number one, signs and symptoms of DVT. See, if a patient develops an acute onset breathlessness, chest pain, tachypnea, tachycardia, hypotension, all in the setting of a deep vein thrombosis, then the probability is naturally high because he is definitely having a predisposing factor. So you will give 3 points for that. Okay. And second is, if the heart rate is more than 100, again you will have 1.5 points for it. If there is immobilization for more than 3 days, that is more than 72 hours, or if there has been a surgery within the past 4 weeks, then again you can assign 1.5 points. If there is a prior history of a pulmonary embolism or a deep vein thrombosis, again you can assign 1.5 points. And if you have hemoptysis, okay, so remember that when you have a pulmonary thrombus that is occluding your pulmonary vessels, if it is occluding maybe one of the smaller vessels, it can cause rupture of the vessels. So along with this dyspnea and chest pain, sometimes the patient also may present with hemoptysis, especially when the smaller vessels are ruptured. So hemoptysis, if it is there, again a score of 1 can be given. If there is an underlying malignancy, maybe the patient is having a prostate malignancy, here again he might be given a score of 1. And it is important that when you make a diagnosis or a clinical suspicion of pulmonary embolism, you should be sure that an alternative diagnosis is less likely than a pulmonary embolism. Okay, so that is again very important, because see, there are other conditions like an acute myocardial infarction or an aortic dissection. Okay, so MI or an aortic dissection. So all these can mimic a pulmonary embolism. So you have got to rule out other conditions as well. So if you rule out the other conditions, there is very less likely chance of such a condition. It is 3 points. See, I'll tell you a clinical scenario. If you have, say, a 28-year-old female 28-year-old female who has been on, say, oral contraceptive pills for the past 5 years, long-term oral contraceptive pills, presents without any other comorbidities, presents with an acute onset of dyspnea, chest pain, and she's having some palpitations, examination, tachycardia, hypotension, elevated JVP. See, in this particular case scenario, you are most likely going to deal with a pulmonary embolism. Do you think that this is likely to be a myocardial infarction? Well, the chance is very less likely. It can be a young myocardial infarction, but with the characteristic setting or the background, this is likely to be a pulmonary embolism. Okay, so this is the importance of the Wells clinical predilection score, or you can say it Wells clinical predilection rule. So the point is that if the score is more than or equal to 4, okay, then that indicates that there is a high probability, okay, high probability of a pulmonary embolism. Okay, that has to be kept in mind. Okay, so that's about the scoring system. All right. Now, what are the, how will you work up? What about the investigation and workup of a patient with a suspected pulmonary embolism? See, suppose you are having a patient now who's the same scenario that I said about the female, elderly female with a fractured neck of femur. Suppose she has developed an acute onset breathlessness. Okay, there is a good chance that this is going to be a pulmonary embolism. So you have got to be aggressive. Okay, so already your Wells clinical predilection rule is saying that she has high likelihood of because she has had some prolonged immobilization. So this is a high likelihood chance of a pulmonary embolism. So you are already suspecting a pulmonary embolism in this patient. So what all are the other steps that you would do? First of all, when you want to investigate, as a screening test, you can go for D-dimer. Okay, you can go for the D-dimer. So the D-dimer would be elevated in case of a pulmonary embolism. Okay, often the value will be more than 500. So, but again, it is not just 500. Sometimes it can be 2000, 3000, 5000. It can be very high depending upon the magnitude of the embolism. So, but remember that this is just a screening test. This is not a confirmatory test for your pulmonary embolism, because D-dimer can be elevated in other conditions also. Even if you have a myocardial infarction, you may have a elevated D-dimer. So then why are we doing this D-dimer is that it is a screening test, because suppose if the D-dimer is normal, then it is very less likely that the patient is having a pulmonary embolism. Okay, so it is more helping us to rule out a pulmonary embolism than to diagnose a pulmonary embolism. Okay, so I hope that is clear. So D-dimer definitely you have got to do. Second is, I am sure you would go for an emergency ECG. Okay, a 12-lead ECG emergency. So when you go for an ECG, the commonest ECG abnormality that you would get in a pulmonary embolism is what? No, it's not your S1Q3T3. Remember, it is the commonest finding is going to be your sinus tachycardia. Okay, commonest ECG finding is going to be a sinus tachycardia. But in a good proportion of cases having a massive pulmonary embolism, you may get a pattern by name S1Q3T3 pattern, which I am sure that many of you would be knowing. This S1Q3T3 pattern, it is relatively a specific pattern, okay, because this is almost a finding which you commonly associate with the pulmonary embolism. And if in your exam they give a clinical scenario and you are able to pick this pattern, S1Q3T3 pattern, that is likely to be a pulmonary embolism. So what is this S1Q3T3 pattern? Let's have a look at the ECG of a patient with a clinically suspected pulmonary embolism. See, simple, it is S1Q3T3, which means in your lead 1, you are having a prominent S wave. Yes, you can see the prominent S wave in lead 1. Okay, and then in your lead 3, okay, you are having a prominent Q wave. Okay, you can see the Q wave here. So prominent Q wave in lead 3. And S1Q3T3, which means you are having a T inversion as well. You can see there is a T inversion here, okay, T inversion in your lead 3 as well. And often there will be associated tachycardia also in this ECG. So this particular pattern is called a S1Q3T3 pattern. Okay, S1Q3T3 pattern. Okay, and then see, you have got to go for a, see, D-dimer is going to tell you it's a screening method. But if you want to go for the investigation of choice, okay, investigation of choice, it is going to be a CT pulmonary angiogram, CTPA. So you give a contrast and you go for the angio, okay, and this will be able to demonstrate the clot, okay. So I'll just show you CT pulmonary angiogram, okay. So yes, this is a CT pulmonary angiogram and you can see the red arrow is pointing in this figure to a clot, and the clot in a CTPA would appear as a filling defect. The contrast will not be able to fill that region, so it will be a region of filling defect. As you can see here, the clot here, and this is another patient with a pulmonary embolism. Here you can see this clot which is affecting the this is blocking the pulmonary artery bifurcation. So such a large clot which will obstruct the pulmonary artery bifurcation is what is called a saddle thrombus. It's called a saddle thrombus. Okay, all right. So that is your CT pulmonary angiography. And remember, previously we used to do the V by Q scan, okay, or the ventilation perfusion scan. So this ventilation perfusion scan is reasonably a standard test for pulmonary embolism, but now we tend to use your CT pulmonary angiography more often. What is done in a V by Q is done using a radioisotope, okay, radioisotope, and you are looking at the V by Q scan. I'll just show you the image, okay. So this is using a radioisotope and this is actually a normal V by Q scan, okay. So you are observing this in various angles, anterior, anteroposterior, okay, and different views are there. But I'll just show you the abnormal one, okay. So normally there will not be any ventilation perfusion mismatch, but here this is actually a patient who has had a pulmonary embolism, where you will have a ventilation would be normal, but again you will have areas where there are no perfusion. So this scan would be able to pick it up. So V by Q scan, see, it can be done even now, okay, but that is often when suppose a patient, for any patient, there is a contrast is contraindicated, okay, because for doing a CTPA you need to have contrast. So if you have an individual who is having say a kidney disease in which the contrast is contraindicated, or pregnancy, those are the scenarios where you can think of a V by Q scan. But other scenarios, CTPA is more commonly used, okay. So I hope that is clear. So now comes to chest X-ray. So if you ask me, why did I first say about the CTPA before the chest X-ray? See, in an acute scenario where the patient, if you are suspecting a submassive or a massive pulmonary embolism, see, it's always better not to waste time, because chest X-ray may not show findings in all cases of patients with pulmonary embolism. So it is, you might waste some time there, nor can it completely confirm a pulmonary embolism. So you would always try to do a CT pulmonary angiography first, or else it must be a case of a low index pulmonary embolism where you can take the patient initially for a chest X-ray first. So let us see what are the chest X-ray findings that you might see in a patient with pulmonary embolism. First of all, I'll just show you a simple pictorial representation. See, this is a picture that has been taken from Davidson's textbook. A simple figure just to show the pulmonary involvement in the lung findings in a pulmonary embolism. I will be showing you the corresponding X-ray findings as well. So just see, you may get pulmonary opacities, okay, you may get pulmonary opacities, and sometimes which can be of scattered pulmonary opacities, or sometimes you can have a well-defined wedge-shaped opacity. That is, when there is a clot in any of the smaller pulmonary vessels, distal to the clot there can be an infarct, which you call as the pulmonary infarct, which may develop into the form of a wedge. So the apex of the wedge will be at the region of the clot, and the base would be towards the lung margins, okay. So you may get a wedge-shaped opacity, and this wedge-shaped opacity is also referred to as a Hampton's hump. Hampton's hump, picture we will be seeing later. And you may get linear opacities also, okay, and which may be bilateral and in the lower zones. You may get pleural effusion also, mild pleural effusion. It is not likely that a patient with a pulmonary embolism develops a massive effusion, but usually a mild to moderate effusion may be there. You may have an elevated hemidiaphragm and enlarged pulmonary artery. So either you may have an enlarged central pulmonary artery or maybe a descending pulmonary artery may be enlarged, and you may also get a oligemia of the lung fields. Okay, so these are the main X-ray changes that you are going to get in patients with pulmonary embolism. So let us see a few of them. So let me see if you are able to spot the abnormality here in this patient who is suspected to have a pulmonary embolism. I think some of you got it right. You have got a peripheral wedge-shaped opacity. Peripheral wedge-shaped opacity here. Okay. So what do you call this? This is called as the Hampton's hump. Okay. So there is a pulmonary infarct with a wedge-shaped opacity. Okay. Hampton's hump. All this is important. Okay. Now next, what are you seeing here? Another patient, anybody can guess this? What is the abnormality? What you are seeing here is that the central pulmonary artery is very much dilated, and this dilated central pulmonary artery in the context of a suspected pulmonary embolism is what you call as the Fleischner's sign. Okay, Fleischner's sign. Okay, very important. Fleischner's sign. Okay, and the next finding that you might, and here also you can see, in addition to the dilated pulmonary artery, you can see the opacities here in the peripheral lung fields on the right side. Okay, and yes, this is another patient, just to demonstrate both of them, your Fleischner's sign as well as the Hampton's hump. So sometimes you have got to have a bit of imagination on the wedge-shaped infarct, because it is not always that you might get the perfect wedge-shaped. Okay, sometimes the apex may not be very much distinct. The base might be well defined, but apex you have got to imagine a bit. So you can have the Hampton's hump there. Now another finding. So in this particular X-ray there are two findings. So are you able to demonstrate that in between the two arrowheads, the white arrowheads, are you able to demonstrate that compared to the other lung fields, the bronchovascular markings are less prominent here on the right side? Okay, so since the bronchovascular markings are less prominent on the right side, it's probably a focal oligemia that has happened there. Now what do you call this focal oligemia? That is called the Westermarck sign. Westermarck sign. Okay, it's a region of focal oligemia. Okay, now just try to appreciate it again, the region of focal oligemia, Westermarck sign. Are you able to appreciate it? Focal oligemia. Okay, now another finding that you can observe if you carefully see, there is a black arrow as well in this picture. Okay, so in this X-ray there is a dilated, you see the descending pulmonary artery is dilated. So what do you call a dilated descending, right descending pulmonary artery, dilated right descending pulmonary artery, and that is referred to as the Pallas sign. Pallas sign. Okay, enlarged right descending pulmonary artery is referred to as the Pallas sign. Okay, so I hope that is clear. Pallas sign. Okay, so these are the important X-ray findings in case of a pulmonary embolism. And remember, in the context of a clinical scenario, they might put this X-ray as well, and you might there will not be any arrows in the exam. So it is important to have a good clinical suspicion so that you will know what to look for. You must know what are the X-ray findings that you expect. Remember, all findings may not be present in a single patient. You might be given a scenario where the patient is having a Hampton's hump, or maybe a scenario where the patient is having a Westermarck sign or a Fleischner sign or a Pallas sign. So based on the clinical scenario, make a logical decision. Okay, which is why I say never get frightened with any case scenarios, however long they are. because longer the question, more will be the number of hints. Yes, the only thing is that the appearance of a long question with an image might just shake you up a bit, but with repeated practice and also a patient-centric learning. Now, what do I mean by this patient-centric learning? See, when you are learning this pulmonary embolism, if you just learn like, okay, pulmonary embolism, this is the mechanism, these are the features, this is how you investigate. See, this is just a factual learning. But see, when you listen to this module, it is always that you try to think of a patient presenting to you. You might have yourself seen lots of patients with a pulmonary embolism. So you think of the scenarios that you have seen. Okay, what would I have done in that patient? And what did I do in that patient? So that will help you in the exam as well to react to a question. Okay, because in a multiple choice question, if you have a long stem question, you have first got to see the question, understand the question, and what is the examiner asking you, and then you have to react accordingly. So if there are two candidates with almost same level of knowledge, but the one person might take a longer time to decipher the question and then answer it. He might take 3 or 4 minutes. Whereas the other one, seeing the clinical scenario of a patient with a hip fracture or maybe a malignancy developing a pulmonary embolism like picture, he already understood this could be a pulmonary embolism. So he quickly looks onto the ECG, and when he looks onto the ECG, he is trying to look for a sinus tachycardia or the S1Q3T3. Whereas the other candidate might be looking at the ECG, first trying to find out what is the rate, what is, is there any STT changes, is there any other abnormality. He might think of all possibilities in the world. So when you deal with a clinical scenario, it's always got to be a targeted approach, which is why if you have a long question, it is always better. I tell my students that if it is a long question, it is better that you read the last line first, just to understand what is the examiner trying to ask you. It might be a case scenario of a pulmonary embolism and you might be asked a treatment. So when you read the question also, after reading the last line, when you go back to the question, you might be able to take out the key points from the question, because in an entrance exam, it is not necessary that you have got to read and understand each and every word in a long scenario. Sometimes may not be possible. So a bit of smartness is also required. Okay, but you should not be careless. But smartness is picking up the right words or the key words in the question. Okay, so that is very imperative here. So you can go for the chest X-ray, I have told you. And what about the echo? What about echo? See, if you have a scenario where the echo machine is available at the bedside itself, it is well and good. At the time of an acute pulmonary embolism itself, you can do an echo. In fact, that is very much advised also. So when you do an echo, what are you going to find? You are going to find a RV hypokinesia and a dilatation. And this RV hypokinesia that you get in the setting of a pulmonary embolism is also known by McConnell's sign. Okay, McConnell's sign. So somebody might ask you a factual question. McConnell's sign is seen in what? It is a pulmonary embolism. So this echo is also important. Now, these are the important investigation modalities in case of a pulmonary embolism. Okay, so I hope you have understood the how will you work up a patient. But remember, if you have not got an obvious cause of a pulmonary embolism, you have got to work it up. Okay, suppose if you have an oral contraceptive pill intake for a long time, like the previous patient that we discussed, then it is quite obvious that he is already having she is already having a procoagulant state. But what if you are not able to demonstrate an actual cause? There is no immobilization, nothing. Then you probably might be dealing with a hypercoagulable state. So in such a scenario, you have got to evaluate for any hypercoagulable state, which requires extensive evaluation. Okay, all right. So that should go hand in hand with the treatment. So it is not like, you find the absolute cause and then treat. You have got to treat the patient first. So now let us go to the treatment of pulmonary embolism. Treatment of pulmonary embolism. So the discussion that I'm going to have with you on the treatment of pulmonary embolism will be based on the 2019 guidelines, okay, of the European Society of Cardiology in collaboration with the European Respiratory Society. See, whenever you discuss a respiratory system, The European Respiratory Society is again one dominant body that would form guidelines. Just like you have the American Thoracic Society and the British Thoracic Society. So you might have guidelines of the American Thoracic Society and British Thoracic Society. You might have guidelines for the ERS. For pulmonary embolism, the most accepted and the standard one is the guidelines of the ESC and ERS. Okay, so let us see what the guideline actually tells. It is not necessary to have a detailed study of the guidelines, but I'll tell you whatever is required from the exam point of view. Okay, now I've taken a few flowcharts directly from the guideline itself, so that you can understand it better. So see, suppose you are dealing with a patient with a pulmonary embolism without a hemodynamic instability. Okay, so you have got to distinguish a patient who's having a pulmonary embolism with a hemodynamic instability and without a hemodynamic instability. Now, what is this hemodynamic instability? Before the guidelines of 2019, there was a previous 2014 guideline also, but there in the 2014 guideline, they vaguely used the term hemodynamic instability. But when it came to 2019, they had better definitions for what is this hemodynamic instability. I'll just show you. Again, this is taken from the guideline itself. When you talk of hemodynamic instability in the setting of a pulmonary embolism, it can either mean a cardiac arrest, that is if the patient has gone for a cardiac arrest and cardiopulmonary resuscitation was required in that individual, or he has gone for an obstructive shock in which his systolic BP is less than 90 millimeter mercury, okay, and vasopressors are required to maintain it more than 90 millimeter mercury. Okay, suppose you have had a systolic BP less than 90, or you are able to maintain it more than 90, but that is with the help of vasopressors, or features of end organ hyperperfusion like altered mental status, because the patient may land up in a respiratory failure. You may have a cold clammy extremities when there is the LV output is low. You can have a decreased systolic blood pressure. So if you have a renal shutdown leading to a oliguria, anuria, and lactate level is high. So this is again features of an obstructive shock. Okay, that is the clot is obstructing the pulmonary circulation, and the consequence of that you are having hypotension, and also you are having persistent hypotension. That is your systolic BP less than 90 or a drop more than 40, which means suppose initially at presentation the blood pressure was say around 200 millimeter mercury, and if after a while the blood pressure is say 130, you do not be relaxed there. See, he has had a BP fall over a short duration of almost 70 millimeter mercury. So if he has had a systolic BP drop more than 40 millimeter mercury, which is lasting for more than 15 minutes, which means persistent hypotension more than 15 minutes. Okay, he's having that low BP more than 15 minutes. Okay, and which is not caused by another condition. See, suppose a patient presents with abrupt onset chest pain, breathlessness. If he is having an atrial fibrillation or a ventricular tachycardia, the problems of a hemodynamic instability can be explained by that itself. So that you will not take. So you have got to exclude any other arrhythmia, hypovolemia or sepsis. Okay, so this is the definition for a hemodynamic instability, and since the guideline has defined what is hemodynamic instability, you have got to know these three terms: cardiac arrest, obstructive shock and persistent hypotension. That is when you say the patient has got a hemodynamic instability. Either of these, okay, either of these three. So suppose if the patient is having a clinically suspected pulmonary embolism, but he is not having any hemodynamic instability. How are you going to proceed? Okay, first of all, you assess the probability of a pulmonary embolism. You can use the various the prediction rules. One is Wells prediction rule. There are certain other prediction rules also available. Okay, now if there is a low risk probability, then you go for D-dimer. Okay, D-dimer. And you do D-dimer, and if the D-dimer comes out as positive, you go for CTPA. Okay, and if the CTPA is able to demonstrate pulmonary embolism, you treat the patient. But if the probability of pulmonary embolism is very high, suppose the 60-year-old obese female with a fracture of the femur and a prolonged immobilization develops a pulmonary embolism like clinical picture. See, do you think D-dimer is going to have much value? Answer is no. because the clinical probability of pulmonary embolism is very high, so that rather than waiting for any D-dimer result, you can directly go for a CTPA, and if the pulmonary embolism is confirmed, you can treat the patient. Okay, but if there is no pulmonary embolism, again, you closely monitor the patient, because this could be a scenario where there has been a pulmonary embolism and the clot has dissolved spontaneously. That is also possible. But you have got to evaluate for other conditions also, which may mimic a presentation of a pulmonary embolism, like a myocardial infarction or maybe a dissection. Okay, all right. So this is how you will deal with the initial the management of a patient with a pulmonary embolism without hemodynamic instability. Now, what is the treatment that you are going to offer? We will discuss that in due course. But for the time being, you understand this is the algorithm in which you are going to work up a patient. And suppose if the patient is having a hemodynamic instability, okay, then it is always advised that you go for a transthoracic echo, because in most centers you will be having an echo machine also available. So if you do a bedside transthoracic echo, you would be able to demonstrate the RV hypokinesia and dilatation. Okay, so you see whether there is an RV dysfunction, and then you look whether if there is a CT, if there is a RV dysfunction there, you see if there is a possibility of doing a CTPA on an emergency basis. Now, suppose if you are not having a CTPA available immediately, okay, you give a call to your radiology department, they say that the machine is out of order and probably tomorrow only they will get it ready. Will you wait for a day to treat this patient? No, because see, you have had a high probability of pulmonary embolism, patient is in hemodynamic compromise, and the echo is showing evidence of, say, McConnell sign also. In that scenario, even if you are not having the facility to do a CTPA, it's always justified that you are proceeding ahead with the treatment for a high-risk pulmonary embolism. Treatment, we will come to it now. But if CTPA is available, go for a CTPA, and if it is positive, you can treat accordingly. Okay, but if the RV dysfunction is not there, you should always think of the other possibilities, because in case of pulmonary embolism with a hemodynamic compromise, definitely there should be a RV problem. You cannot have a pulmonary embolism, a massive pulmonary embolism with a perfectly functioning right ventricle. It's impossible. Okay, so this is how you would work up a patient with a hemodynamic instability. Now, how will you treat the patient? You have understood the basic algorithm. Now, suppose if it is a patient with a massive pulmonary embolism and there is a hemodynamic instability, okay, a massive pulmonary embolism with a hemodynamic instability, okay, or even a patient with a submassive embolism with a significant features, and he is developing, say, worsening of his saturation. So in such a scenario, okay, the best treatment that you can offer is that you can go for a thrombolysis, because it is probably a large clot. See, when you deal with a massive pulmonary embolism, you are likely to have a big clot. Remember, I told you, larger the clot, more likely are the severe manifestations. So if you have a large clot in your pulmonary artery, your first target is to lyse the clot, because otherwise the perfusion will be significantly affected. So you try to lyse the clot. Now, what are the options that are available? You have Altiplase that is available, recombinant tissue plasminogen activator. Altiplase is available to lyse the clot. But remember one thing, even streptokinase and urokinase are also approved. Okay, but the agent of choice definitely is going to be your Altiplase. So what is the dose of Altiplase in pulmonary embolism? It is going to be 100 milligram, which you give as an infusion over 2 hours. 100 milligram over 2 hours. Now, when will you give the thrombolysis? Remember, earlier the better. Earlier you thrombolize, earlier the better. And the guideline, the 2019 guideline also states that if within 48 hours you are able to thrombolize, it gives the best results. Okay, it gives the best results. But you can thrombolize a patient. Okay, suppose in certain scenarios, if you are working in a tertiary care hospital, you might get a patient who has a pulmonary embolism and probably he is referred from another hospital. So already for say another week, for a week he has been there in the hospital and he's probably having a pulmonary embolism, and by the time the patient reaches you, he is still very much symptomatic. Okay, so remember that the guideline says even up to 14 days from the onset of symptoms, you can think of lysing the patient. Even up to 14 days. This is again in contrast to your stroke, okay, where the window is very much shorter. Here up to 14 days you can think of thrombolizing the patient. Now remember, the agent of choice is going to be your alteplase, but also remember one thing: when you give alteplase to this patient, make sure that the patient is a candidate for thrombolysis, okay, because sometimes a patient might be having an active peptic ulcer, he might be having some coagulopathy. So remember that when you plan to thrombolize patients with massive pulmonary embolism, always look for the contraindications. Now this is again taken directly from the guidelines. Just see the contraindications, what the European Society of Cardiology and the European Respiratory Society is saying about the contraindications to thrombolysis. There are certain absolute contraindications, that is, he has had a hemorrhagic stroke, any history of a hemorrhagic stroke, or an ischemic stroke in the previous 6 months. Just that, the contraindications will be the ones in which there is a high possibility of a bleed, okay. And if you are having a central nervous system neoplasm, if you are having a large intraaxial neoplasm in the brain, there is a likelihood chance that the patient might bleed. If he has had a major trauma, surgery or head injury in the previous 3 weeks, a bleeding diathesis or active bleeding, okay, suppose he is having an actively bleeding peptic ulcer, it's an absolute contraindication, okay. Now there are certain relative contraindications. That is, if he has had a stroke but it is a TIA in the past 6 months, if he is already on oral anticoagulation, a pregnancy or first postpartum week, non-compressible puncture sites, okay, if there is a bleeding from the, suppose he has had a bleeding from a non-compressible site, okay, so in that scenario, suppose, if you have a bleeding from your, say, radial artery, it is a compressible site, no? But if you have a bleeding, suppose from a large vessel which has happened, do you think it is, if it is not a compressible site, you are going to land up in a devastating blood loss in that patient, okay. So if there are non-compressible puncture site bleeding, okay, then there is it is a relative contraindication. And the other relative minor contraindications are infective endocarditis, liver disease, active peptic ulcer, okay, and refractory hypertension. These are relative contraindications. Okay, so just to keep this in mind, okay, I won't say that you must by heart what are the absolute contraindications and relative contraindications. Yes, in your stroke it is more important to memorize the absolute and relative contraindications, but here in general you might know that when you have a tumor, when you have an active bleeding diathesis, when you have had a recent surgery, then there is always a risk of bleeding. Okay, so keep that in mind. So remember, this treatment is for your massive pulmonary embolism. Suppose you have a submassive pulmonary embolism and probably you are not having a hemodynamic compromise. In that scenario, you will have to go for anticoagulation. Okay, you will have to go for anticoagulation. And remember, because there is no role for the thrombolysis, because what happens is that, if you ask me, sir, you said lysis of the clot is a priority. So in massive pulmonary embolism, you lyse the clot. Then, why not lyse it here also? See, in a submassive pulmonary embolism, most likely the clot will be in the smaller vessels. So if you lyse such a patient, what will happen is that when you lyse a clot, always there is a chance that the smaller clots would dislodge. Okay. So there is a chance that the smaller clots will dislodge further and maybe one of the vessels may be affected and there may be a pulmonary infarction. Okay. So it is because of that you will not lyse a patient with a submassive pulmonary embolism. So the question can be there that if you lyse a patient with a massive pulmonary embolism also, isn't there a chance that there is dislodgement of the smaller emboli? Yes, there is a chance. But here, you have to see. When you have a large clot that is totally obstructing the flow, in such a scenario, you somehow want to restore the flow there. That is your priority. So it is always about priorities. Okay, as is in life, it's always about priorities. So here, When you deal with a massive pulmonary embolism, your primary target is to lyse the clot. Submassive pulmonary embolism, lysis is not your priority, you anticoagulate the patient. That is important. Okay, so if you ask me, so does that mean that anticoagulation is not required for a massive pulmonary embolism? Well, first in a massive pulmonary embolism, thrombolyze. After the thrombolysis period, definitely you might require anticoagulation in the patient for sure, because the patient might again develop a thrombus or an embolic episode. Okay, so that is the importance of anticoagulation. So when you think of anticoagulation, what are the options that you have? In the acute stage, you can go for a low molecular weight heparin, okay, or maybe a fondaparinux, or you may go for an unfractioned heparin. So the 2019 guideline favors the low molecular weight heparin and fondaparinux over the unfractioned heparin, because your unfractioned heparin would have constant monitoring that is required. Okay, you would have to have a APTT monitoring. But one advantage of your unfractioned heparin is that you can actually have an antidote, because you are having an antidote, that is your protamine sulfate. Protamine sulfate. So you have got to anticoagulate the patient in a submassive pulmonary embolism as well as an acute pulmonary embolism after your thrombolysis. Okay, so after your thrombolysis, you will not anticoagulate immediately. Only after another 24 hours you would anticoagulate, because otherwise there is a chance of bleeding. So initially you would anticoagulate with your low molecular weight heparin or fondaparinux, some scenarios unfractioned heparin, and then what you would do is that you would introduce anticoagulants also. So either you can go for a warfarin or the non-vitamin K oral anticoagulants, which are your NOACs. Okay, so what you do is that you can bridge with a warfarin and low molecular weight heparin to begin with, maybe for the initial 3 to 5 days, and then switch over to warfarin. But if you ask me, see, among warfarin and the NOACs, what is preferred? See, it is the NOACs that are preferred. The guideline prefers NOACs over warfarin in the treatment of pulmonary embolism. Okay, so remember, the purpose of adding anticoagulation is not to lyse the clot, it is to prevent further clot extension or maybe another clot from forming. Okay, so you can go for the non-vitamin K oral anticoagulants. You know that various anticoagulants are available, like dabigatran. Okay, you can have rivaroxaban, apixaban, edoxaban. So all these are available for the management. Okay, the NOACs are available, and you have the NOACs have a distinct advantage over warfarin. I have already discussed the comparison of warfarin versus NOACs in the neurology module, so you can just have a look at that under the cardioembolic stroke, where I have compared the advantages and disadvantages of each of them. So remember that you can go for the NOACs, and they are the ones which are more preferred over the warfarin. And if you can go for warfarin also, because many of the scenarios, sometimes cost problems may be there, you will have to go for warfarin. So the target INR, the target PT INR would be that of to maintain it between 2 and 3. Okay, the target INR would be to maintain with the 2 and 3. Okay, and see, you will follow up the patient well, and you will maintain the patient on the INR of 2 to 3. Okay, so if the patient is on warfarin and if adequate INR is not obtained, you can think of increasing the warfarin. But NOACs, as you know, is fixed dosing. Okay, so if a particular NOAC is not able to give you the benefit, you can switch to an alternative NOAC. Okay, or maybe even switch back to warfarin. So long-term anticoagulation may be required. So in many scenarios, like say an antiphospholipid antibody syndrome, you might require a long-term anticoagulation. Okay, but in certain scenarios like malignancy, again here you would require long-term anticoagulation. But then if you might ask me a question like, see, if you have had a malignancy and the patient developed a pulmonary embolism, after some time the malignancy was treated, then will you continue for lifelong? See, you do not have definite guidelines for that, but always long-term anticoagulation is the one that is preferred for such scenarios. Okay, so you will go for long-term anticoagulants. Now, if the patient is having like a contraindication for anticoagulation, okay, if he is having a contraindication for anticoagulation, or suppose he is saying that, he is refusing to take anticoagulant tablets, probably he has asked Professor Google, and Professor Google says, this anticoagulant has lots of problems. So he says, doctor, I do not want a oral anticoagulant, I want something else. So in that scenario, when the patient is totally not willing for an oral anticoagulant, the next option that you have in front of you is a inferior vena cava filter, okay, inferior vena cava filter. So this can also be used in a scenario where, in spite of anticoagulation, patient is developing a recurrent episodes of pulmonary embolism. Okay, in that scenario also you can go for a recurrent episodes in spite of anticoagulation. In that scenario also you can go for a inferior vena cava filter. Okay, but I'll just show you a inferior vena cava filter that is in situ. Are you able to see this? Okay, this is the filter. Okay, so this is this is with the help of a catheter, and as a guided procedure you will do this, and the filter will be in situ, and this probably decreases the incidence of embolic events, because I told you, remember, the thrombus in the deep veins of the lower limbs, they'll get dislodged and travel upwards. Okay, so if you have an inferior vena cava filter, it would somehow prevent the propagation of the thrombus. But remember, this is not a 100% proof procedure. You can have patients developing embolic episodes even after inferior vena cava filter. Okay, so that also has to be kept in mind. So the summary of the treatment of the pulmonary embolism is that acute massive pulmonary embolism, you thrombolize as a high priority. But remember, along with the thrombolysis, it is very important to have a hemodynamic support also, because do not just thrombolyze and keep waiting for the blood pressure to improve. You have got to give your inotropes if required. Okay, so that has to be kept in mind. Sometimes fluids might be required if the patient is in significant hypotension, but mind you, that is only when the hypotension is so severe, because otherwise what happens is that your RV might be failing, and if you put more fluid in, you might actually worsen the fate of the right ventricle. So fluid in case of RV, usually you do not supplement fluid, but only when you probably think, you are suspecting that this could very well be a inferior myocardial infarction also, because you can have similar clinical presentation, or you might feel that the BP is very low. Only then you would think of some fluid supplementation. Otherwise, manage with inotropes. Hemodynamic stability has to be provided, and then subsequently go for the anticoagulation, and then also for the submassive variety, there is no need of a thrombolysis. You would go for an anticoagulation. Always NOACs are preferred over warfarin. If you go for warfarin, you try to maintain the INR in the 2 to 3 range. Okay, so remember and try to work up and find out why the patient has developed the pulmonary embolism, because he might be having a procoagulant state. So you have to deal with that scenario also, so that the patient does not develop recurrent episodes. Okay, so this is a comprehensive overview of pulmonary embolism. This is a very, very important topic, and you have got to know it very, very well. Okay.